Continuing from last time, this time I will talk in more detail about the geometry of the crestal module and abutment connection. So the third theme is the shape of the crestal module. This is quite important because there are various types of implants in the world. The top part of the fixture is called the crestal module, and this shape differs for each type of implant. Right? Let's examine why the shape of the crestal module is different. In fact, this is an illogical crestal module shape. This also doesn't make sense, because screws originally have a pitch that allows them to rotate and fit in, but this is not pitch, it's a shelf shape. It's simply carved out in a shelf shape, and in reality, fixtures with this kind of shape break more easily. So the Baiken implant is like this, and even though the Baiken implant has a diameter of 3.3 meters, it can break. Shelf shapes tend to break a lot. Double thread fixtures break less than single thread. Ones and triple thread fixtures break even less than those. The new slock implants, TLX and SLX, are all triple threaded. The new implants are all triple threaded, allowing them to be placed twice as quickly and to break less easily. This is the original Torx++. The original version is double threaded. This slock is also double threaded. So triple threads are said to be a bit more stable against horizontal forces compared to double threads. I think a triple thread fixture might be slightly better, but there are probably only a few implants available in Korea that are triple threaded. Even abroad, triple threads are very rare. The crestal module of this model simply has a groove. The crestal module of the slock fixture has threads. I think differences might arise in these aspects. The shape of the crestal module is very important. The reason the shape of the crestal module is important is that initial crestal bone loss is one of the key topics in all implant treatments. There's a professor named Albrechtsen. According to Professor Lee, after 1 year of implant prosthetics, post-loading, bone resorption occurs around the dental implant, and it's said to be about 1.5 meters. The fixture was placed at the bone level, but the bone dissolves downward by 1.5 meters. Conversely, the question is whether it would be better to place it 1.5 meters deeper. This is something I extracted from an old paper. It also states, if the additional bone loss after 1 year of post-loading does not exceed 0.2 millimeter, it is considered a success. Therefore, crestal bone loss is a phenomenon that all implant companies are very fearful of, and if this can be overcome, I believe it would be a very good implant. Our slock implant has very little or minimal crestal bone loss. I think this is the difference compared to other implants. Additionally, after about a year of occlusal loading, the bone matures more, continues to receive occlusal force, and becomes denser. Professor Lee also considers about a year for bone adaptation. Then I'm saying, it would be good if the crestal bone loss doesn't progress further. And I keep saying, it would be great if we could prevent bone resorption. The bone around the implant does not dissolve from below the fixture, it goes down from the crestal side of the fixture. So, because it's coming down from above the fixture, if the upper part is defended, then the initial bone loss on the crestal side is defended. The fact that the implant lasts a long time means that the long-term results are good. So many dentists are interested in this area. As far as I know, this implant seems to be a Swiss product. Maybe? I think it's a BLX. I'm not sure though. But anyway, I've placed the fixture like this. I placed it like this. Then the bone on the crestal module side is dissolving like this. As soon as occlusal loading occurs, the bone dissolves right away. However, I also placed a fixture that is too thin here in the central incisor. It seems that I placed a fixture with a diameter of about 3.75 mm. So this is thin. So the abutment connection side keeps separating. Then crestal bone loss occurs. If this continues to go down, the implant comes out. For this reason, a lot of effort is made to prevent initial crestal bone loss. This is probably similar content, and no matter how deep it's implanted, it still dissolves up to the first thread. This is too thin as well. Then if you look at this, it is explained that crestal bone loss occurs downwards without exception. This is a biohorizons implant. Everything has dissolved here too, up to this point. This looks like a brain mark implant copy, and it also dissolves completely. This is the biohorizons implant I mentioned last time. Crestal bone loss occurs. So what should we do with these implants? If the bone dissolves down to the fixture thread, it becomes a problem. Because the screw channel becomes dead space, secondary inflammation continues to occur between the screw channels. Foreign bodies entering this area, or remnants of dissolved bone, toxins, and such things continuously induce secondary infections. So, as you can see here, the crestal module has been made entirely straight. Why? Because it's going to dissolve up to here, so the crestal module has been treated with laser lock to be smooth or to help soft tissue attach well. But this also looks prone to dissolving. That's because you can see there are a lot of gaps. So it's an implant with micromobility. As a result, it's faced with the situation where continuous crestal bone loss is inevitable. Here you can also see the abutment connection is attached here. So it comes down here to create a smooth surface, allowing soft tissue to attach while maintaining bone beneath it, thus designing it in such a way. In this way, we can see that crestal bone loss plays a very important role in the maintenance of implants. Last time I talked a lot about bone remodeling. It's the same thing. So in the end, the bone keeps changing. Modified, modeling, remodeling. Modeling occurs regardless of location. This can now be seen as changing the shape and size of the bone, and remodeling involves not only bone resorption but also bone deposition. The most representative case is the area where teeth have disappeared. It is written that the bones around implants undergo very rapid remodeling. Ultimately, this is related to the bone turnover rate. This is also a content extracted from that paper, and most of this information is generally agreed upon. Since most people do not understand well, they think that once bone is formed, it is continuously maintained. However, that is not the case. You should think that old bone is continuously being resorbed, and new bone is being deposited, leading to the disappearance of old bone and the formation of new bone. There is a professor named Frost. This professor looked at the histologic patterns for bone in 4 different patterns, the first being pathologic overload zone, the next being mild overload zone, the third is the adapted window zone, and the fourth is the acute disuse window zone. So it is expressed like this graph. As I showed last time in the identification of implant, treatment if you don't exercise, bone density decreases. This is a graph of normal conditions, and when you exercise, there is bone gain like this. Then, if you excessively overexercise, fatigue fractures eventually occur. So, first understanding this graph about bone remodeling, if you look at this image, you can see that cells become more activated, and as woven bone continues to increase, it ultimately leads to fractures. This is the process of spontaneous fractures. Ultimately, the implants are constantly subjected to stress. The bones surrounding the implants are exposed to occlusal loads transmitted through the fixtures. So, when you are in the adapted window zone, the bone remodeling occurs similarly to the bone turnover rate in our body. Generally, I understand that the bone turnover rate around the implants increases about 3 to 5 times. And then it stabilizes after lamellar bone formation. However, there are cases where an implant suddenly comes out after being used for about 8 or 10 years. If you look closely, the patient's chewing pattern has changed. It may be a situation where the opposing teeth have fallen out, causing overload on the implant, or the adjacent teeth are shaking, resulting in a loss of occlusal support. Then the second factor is the host factor has changed. The bone healing capacity has decreased. So the host factor has changed. Additionally, there is a change in the occlusal environment. So eventually it transitions to a pathologic overload zone. At that point, the bone around the implant will start to dissolve, leading to a sudden failure. There is almost no disagreement on this. Those who place implants say they don't understand why it's suddenly failing. They also say that once you get an implant, you should use it for a lifetime, while pessimistic individuals say that if it lasts over a year, it's considered well used, as there is so little understanding of this. And even after placing the implant, we need to manage the patient for a lifetime. Otherwise, we have to place implants that are as thick and long as possible. Because we need to consider the surface area of the fixture. We need to think about the force applied per unit area. So we must use thick and long ones. Using wide diameter and long fixtures increases the surface area. Then we look at what zone the bone response corresponds to based on the force per unit area. So, as I keep saying, eventually the type and size selection of the implant is the most important. Looking back even now, it seems that the sizing of the implant was the most crucial. So we need to have various sizes. Having various sizes allows for appropriate responses to different environments. In the past, there was also a saying that even with just a few implants, one could respond to all situations. There are still places that perform surgeries that way. One connection. I really don't think that's the right approach. However, in our country, it's all one connection. I don't think that's the case at all. I'll tell you more about it later. That's absolutely not true. So, the larger the surface area of the fixture, the closer it gets to this adapted window zone, or the mild overload zone. However, if you implant a fixture with a small surface area, it easily corresponds to the pathologic overload zone, which is dangerous. So this is important from our perspective. I saw in a book that around this implant there are bone cells referred to as the adapted window. The created bone cells and the absorbed bone cells create a balance. Right? So by looking at this, you can easily understand the window theory of bone remodeling. It was expressed as 50 to 1500 NCM microstrain, and when this level of force is applied, a balance is achieved between modeling and remodeling. So this is important. It needs to transition to a steady state. Lamellar bone needs to form, and there must be load-bearing bone for maintenance. Then, within 1 year, the rate of change is about 18% for trabecular bone. Cortical bone is 2% to 5%. The letters are yellow, so it's hard to see. It's considered normal. Trabecular bone takes about 5 years. It gets replaced once every 5 to 6 years, and if we think cortical bone is 5% per year, it would take about 20 years. However, I think I've judged the bone turnover rate to be too low and too long. In conclusion, this is the scientific evidence we can generally accept. You need to conduct a good study here. So there is no periodontal ligament, and there is direct bone contact, but it is not ankylosis. It is bone contact. Osseointegration seems to be a misunderstanding. Next, since it shows a vertical bone loss pattern, it comes down from the initial crestal bone loss. That's the content. So when a lot of stress is transmitted, it will cause a lot of stress on the bone. Then, modeling and remodeling occur, and this happening due to the mechanical environment is the general scientific basis that we can accept. In the end, the density of periimplantal bone can be said to be the result of mechanical deformation caused by microstrain. Logically, it has been organized. Next, what does periimplantitis mean? It can be said to be the result of mechanical deformation caused by heavy overload. So far, we have looked at content that can be generally accepted. This is a paper unrelated to this topic, but I found something like this. It seems to be a Chinese paper from Sichuan. Sichuan, so probably over there. If it's Sichuan, then it's Sichuan province. The Sichuan Huaqiu Dental Institution is very famous. It's number 1 in China. Then there's Peking University, and then Shanghai Jiao Tong University about that level. That's the ranking. It's very famous. The paper published there has a battery placed inside the implant. They included iron in the outside hydroxyapatite and observed the amount absorbed. And they did bone labeling with tetracycline. If you look here, this side has a lot of labels. So what does that mean? What this means is that bones are being rapidly produced here. So I see that in this photo, iron has been detected here, and when layered, it appears that hydroxyapatite is not being absorbed due to this battery and is remaining around the implant. This magnetic force is holding it in place. So this is a paper that concludes that it works better. So right now, to what extent have we come? If tetracycline is taken up, we can know about the new bone formation around here, and we can know the bone turnover rate. So we regularly give tetracycline to patients and check the tetracycline uptake of the osseointegrated implants. And through the experiments, we found that good implants have a low bone turnover rate around them. On the other hand, For poor implants, the bone turnover rate around the implant increases, leading to a pathological fracture at some point, which is ultimately explained as the mechanism by which the implant comes out. In the paper I read, experiments were conducted based on the design of the thread profile. However, if the size changes, the results will change, right? Think about it. If the surface area of the fixture increases, the bone turnover rate decreases. As far as I remember, the implant with the worst results in the experiment was the stereos implant, because the threads are small. There's a specific product, the one you used last time. The threads are sharp and extend to a thickness of 0.1 millimeters. Then the thread does not bear stress, but plays a role in stressing the bone. Thus, the bone turnover rate around the fixture thread increases significantly. So, it's easy to insert if you reduce the thickness of this thread. However, it's a design that inevitably increases the bone turnover rate around the implant. So those things are not good. I expressed it this way, but I don't know. If you increase the size of the thread a lot, there must be a limit, right? It breaks because there's no bone inside the screw. If you make the thread larger here, the screw hole becomes narrower. Then the bone narrows down. Then there is a difference in strength between the metallic thread and the bone quality. So in my opinion, about 1/3. I think the bone thickness between the threads should be about 3, and the thread thickness should be about 1. I think about a 3-to-1 ratio is good. So it stands out clearly. It stands out, this. I remember there was an implant with a 1-to-10 ratio. The hole was 1 millimeter, and the thread was 0.1 millimeters. So that's too spread out. So now, the thread bends. It can bend even in the chewing process. So there are many hints obtained here. That's why we need to plant a wide and long large fixture as much as possible, because we need to lower the bone turnover rate around the implant to an adapted window zone. This kind of design is a wrong design, but since it increases about 5 times, pathologic bone fractures occur. I've seen a paper like that once. So in cases where it's increased about 5 times compared to the adjacent area, that's a dangerous situation. But anyway, if there is cortical bone anchorage, what happens? Cortical bone has a slow bone turnover rate. So in the end, cortical bone anchorage becomes very, very important. Some say that lamina dura forms around cancellous bone, like this, because the implant is a foreign body. The bone has to protect against foreign bodies, so it creates lamina dura here. Cancellous bone creates cortical bone. You can feel it when you actually remove the fixture. When you remove the fixture and curette the surrounding bone tissue, it becomes hard. So it seems to be true. The defensive mechanism keeps developing. When the lamina dura forms, the bone turnover rate eventually decreases again. This creates a favorable situation for absorbing and distributing the occlusal load on the implant. More importantly, having original cortical bone anchorage is much more advantageous. That's why thinner fixtures can withstand it. The fixtures used in the anterior region are thin. In that case, the bone turnover rate will suddenly increase, but the reason the bone can withstand it is probably due to the important role played by the cortical bone anchorage I mentioned earlier. This is how it can be explained. There are several shapes of the crestal module. Here, it also melts up to the first thread, up to 1.5 meters. This is the brain mark implant. A screw is made here. When inserting, it is implanted up to this point. This is all done in such a way. The Astra implant type is somewhat ambiguous. So once it melts, it's unmanageable. And these things, let's take a look. It's a butt joint. Butt means that it meets at a right angle like this. Like this. That's called a butt. Cold welding doesn't work, and it's an external hex. Micro movement occurs. There's a one-stage implant, and there's an internal hex too. It's all very troublesome. The microthread zone was a bit of a different story, but anyway, the microthread zone seems to have been made like this because the thickness of the fixture is thin. Yes, if you make the screw thread and thread pitch smaller, the thickness of the remaining tissue around the abutment connection fixture becomes thicker. So it seems that the success rate was higher. In the case of Viken implants or slock, they have a step sloping shoulder. We have a step sloping because there is a step like this. Right? So I think this is good, and ultimately the one-body implant is the ultimate implant. Considering the micro-movement aspect, the one-body is the best implant. However, the one-body implant market is less than 1% globally. So our domestic one-body implants are not being exported. One-body is not accepted anywhere. Why? Because the prosthetics don't work. If the prosthetic path doesn't match, many difficulties arise in the prosthetic area. So I think one-body is the ultimate implant. Anyway, now that crestal bone loss is eliminated, it's good. The reason why that one-body was accepted domestically isn't because of the fixture design, but because one-body has various advantages. But now, it seems like it's being explained that the fixture design is special, or that the manufacturing technology or procedure method is special. In my opinion, the same phenomenon occurs with one-body. I've seen a lot of one-bodies. To prevent crestal bone loss, they designed the crestal module, but my thoughts were a bit different. The various designs of the crestal module were due to crestal bone loss. So, what if we think about it the other way around? In this case, I don't know where to implant. I believe that when I remove it, bone will form here, at the height of the crestal bone, and between here. Yes, when connecting to the height of the adjacent bone. So now I was talking about the baseline bone concept. What that means is if you draw this line, I think this line is ultimately the line where the bone will regenerate. That's how I think. Now I removed it. There's nothing else. And I don't do bone grafting. I just wait. Something fills in. Then I implant. I slightly implanted the fixture subcrestal. For 216, I also implanted even though there was bone for 217. Still, it's a bit unstable. I did a socket lift and then the restoration. Then the bone rises. The rest is the same. Like this. Then looking at this picture, everything is in poor condition. This one is in pretty bad shape. The first one has melted. Because this tooth is weak. This tooth is also weak. Only this one is receiving strength, and I couldn't insert a larger size fixture. So the bone has melted all the way to the crestal module top. It should be able to explain itself. Only then can I objectively treat the patient. If I cannot explain the treatment I've done, I cannot secure objectivity. If I cannot secure objectivity, ultimately the basis for treatment disappears. So I think like this, and I just have to wait. I inserted a really large fixture on top. I have now realized. So I inserted a fixture with a diameter of 811 mm, and it was soft bone. It was a case that struggled due to the wide sinus. As you can see, the bone below this sinus was only 1 or 2 mm. Everything was pushed out, and I solved it using palatal anchorage. Then you just have to wait. As you can see, the bone has come up a lot. Here too, the bone should come up. It has come up below as well, but if you look at the next one, you can see the regeneration. Things like this. It is a bit less developed here. This place is now receiving loading, and it seems to be colliding. Here, it is nicely organized at the connection point of the abutment post and the fixture. In between, an implant was also placed here. It's not a very good case because there is symmetry. Let's take a look at another case. It's concerning. Patients with periodontitis all come in like this eventually. So with the current protocol, we can't solve this. We can't resolve it. How do we solve this? So now it makes sense to use a system that implants deeply or implants that promote bone healing with the baseline bone concept. That's why quite a few people are coming in like this. These patients continue to come. This patient will eventually keep coming until all the implants are done. Here, we need to wait a bit. The bottom part is implanted, but it's a bit precarious. If you look, once it's implanted and we wait, the bone will rise up. Bone will form above, and there will be socket lift below. Right? We didn't place any bone above either. I'm just putting up the existing bone. It's not that I put in bone. I asked to remove the other side too. It's not that I put in bone on top either. I just pushed and did the implant. Then, this is the result photo. The bone has filled up tremendously. If you look here, it's rising up. Everything is rising up, right? This side will eventually rise up as well. This side is also in the process of rising, and so is this side. If you can't believe this, it's hard to provide treatment. So, other implants lose 1.5 millimeters within a year, and every year there is a 0.2 millimeter crestal bone loss, but this one actually grows even more. Because of this, people using slock have good relationships with their patients. At first they don't realize it, but after about 2 years or 5 years, the patients start to know. It doesn't smell, and the bone keeps growing, so they understand a lot. The way we design the crestal module takes crestal bone loss into consideration. So I think the most difficult part was the relationship between crestal bone and geometry. Immediately after extraction, this style of implant is good. It fills the top completely. After absorption, you can place this type of implant. This is the bone. They are mostly placing something like this. How about this? The advantage of the deep placement system is because of this. When you do this, it appears sharp from the side. It dissolves within a year. It disappears right away. It's scary. That's why most cannot place wide implants. If you place a wide implant, the bones above become thinner. Then during loading, the bone immediately dissolves. The same goes for this side. And then while placing, it becomes exposed. Then you have to do bone grafting and GBR. GBR cannot be successful. Because think about it. You place bone here. Then the bone must receive stable blood supply from inside to outside to form properly. Think about it. Just because it's placed on the surface of the implant below doesn't mean it will become bone. That is beyond common sense. I tried placing a bit deeper on this side, and it turned out like this. A lot of bone grafting is done on that one side. These cases. This is the same. This is also okay. And likewise, I've planted deeply a lot. Since I've planted deeply like this, it becomes like this. We've ended up like this. So now, in the end, even now, all implant companies, crestal modular design is they have developed bone-level implants and are forcing us to plant subs. Every company is explaining to implant 1 meter to 2 meter deeper, but the prosthetics can't keep up. Prosthetics can't be developed for implanting at this subcrestal level. It doesn't work well for crestal use. This is the situation. I've done some calculations. Then, there might be people who have implanted equicrestal or bicortical. Where is this commonly done? In the case of maxillary anterior teeth. Where there is a sinus. In the molar area. People who have implanted equicrestal. This is how it has been done until now. Bicortical is better. This is what has been expressed. It's the same for mandibular anterior teeth. In the case of the inner mandibular molar area, it doesn't work well because the nerve goes underneath. Equicrestal and bicortical are shown to be the best protocols, otherwise they are mostly planted like this. Equicrestal with monocortical. What happens if you plant it deep? It becomes subcrestal but will be cancellous. That's why there were many failures at first. The reason we were scared of sub was because of this. However, there is also a solution to this. If you plant it buccolingually to catch the cortical bone, no problems will arise. Wide is absolutely necessary. This is the best. In cases where it's subcrestal but gets anchorage from below, these cases are the best. If the crestal bone is thick, this is also possible. Bicortical implanting subcrestal is also possible. We do this a lot. Because in cases like knife edge, even if you plant it deep, one side will catch the cortical bone. On the contrary, knife edge yields better results. You can plant it deep, and it catches bicortical, so it seems better. Therefore, I think you need to properly assess which side of the procedure you are doing. So in the case of anterior teeth, it becomes more typical, right? The immediate impact after extraction is that this is a somewhat advantageous point. But if you plant it wide, it's the same. There's no need to plant anything thin below the molars. You can plant it wide. It's because you're thinking of it as the same size. So if you see, the more absorption there is, the much better it becomes. A narrower crestal module is much better. The same goes for the mandible. You need to look at it intuitively. Don't think of it too complicatedly. It's also a problem when vertical pressure is applied. Is this a bit more advantageous? It applies from the side, right? When horizontal pressure is applied, it's similar. When both horizontal and vertical pressures are applied, I think this will also be similar. This is our slock. It's really good. Having a step like this on the crestal side, I think it's a tremendous advantage. This was actually a bit of a coincidence. At first, we started to develop implants that could do both external and internal, but this yielded better results. So we are continuously making it without creating a sloping shoulder. Others might find it funny. There are internal Baiken implants, solid abutments, and screw-retained abutments. It's a very complex design, right? Yet it's simple. The prosthetic options are diverse, and the occlusal force was quite good. So the success rate is pretty high. So, when we talk about the crestal module and crestal bone loss, you can get a sense of the concept of implant design. The bone is heavily filled. Yes, that's right. Anyway, it's cleverly designed. That's it. It's a matter of accident, actually. It started as coincidence. But I have no plans to change it in the future. I think we can talk about the abutment shape and examine the cases and then wrap it up. But we need to finish a bit late today, right? It's very important. So, there are various abutment connections, such as external, internal, Morse taper, locking taper, and these days, there's Torx++ coming out. There's nothing else besides this. So you can explain it like this. The internal and external are the butt screw. We consider these to be the same. When using a fountain pen, we insert it like this. We regard it as internal when it's positioned like this, and if it's flipped over, we consider it external. The Morse taper has a taper section. So this is referred to as the internal system. Astra implants have an angle of 11 degrees, which is 22 degrees on both sides. In our country, everyone uses 22 degrees. The reason ITI implants are good is that they are at 8 degrees. That's 16 degrees on both sides. So domestic implants are currently being matched to 15 degrees and 16 degrees. Is that the new model implant from company M and the K implant from company O? I believe that is 16 degrees. Yes, 8 degrees each. It's a copy, again. The ankylose implant is at 574 degrees. Locking taper is often done at 3 degrees. Now we have a hex on the inside and there is a thread. As for Torx, it's 3 degrees, so we manufacture it at 6 degrees on both sides. So, internal and external are basically the same shape turned upside down, so I think they are the same. Hexes. But the biggest problem is this, because when it's internal there is an implant, an abutment, and a bolt. So this becomes thinner. And because it keeps bending, microgaps form, the implant breaks, the abutment breaks, the bolt loosens, and this continues to repeat. So I don't know why they insist on internal connection. I don't understand it. Even now, successful implants are external. I also haven't lost an external implant. Not a single brainmark implant has come out. It's been almost 30 years and it hasn't come out. So even now, is it Cheonam National University's Engineering Medical School? They still don't use internal, only external. Because it's too complicated and this is too weak, so subsequent problems arise. Many people I know don't use internal because of this. So that's why I introduced novel biocare implants first. Next is the Neodent implant. There is also this. The TLX we developed this time is similar to this. The Straumann implant has slightly reduced the angle at the top. As a result, its height has become a bit shorter. It probably won't be less than 2 meters. The results of this implant were good. So everyone is in trend to create 16 degrees. And this is the novel BioCare implant. This kind has also emerged. Astra implants are making these because they can't do it themselves. Is this an Atlantis implant? It's a Straumann implant, I'm sorry. The Straumann implant also makes this. It's a 15-degree internal connection. How is it structured? It's set up like this. It only holds in 4 places. Just 4 places. Why? Because it breaks too much. There is also an old connection in Astra implants that most of them in Korea are copying. The product with a 22-degree angle and hexagon at the bottom is no longer coming out. They've given up, but it seems they will continue to make that in Korea. They are continuing to produce it. I reduced the angle and gave up on the hexagon because the bottom breaks too often, so I designed and created it this way. It has become thicker like this. The implant has become thicker. So it seems that a lot is being done like this now, and now the first... I'm sorry. Is this the previous ITI implant? It is the ITI implant. I'm sorry. It seems that Astra implants also tried to follow this, but failed in the domestic market. This is a company D implant. When you turn the screw, it all gets crushed. So I believe there is still a product available now. This is a 12-sided one with hexagons done twice. Astra implants have produced something like this, and sometimes they also use zirconia abutments. This is quite brittle. Everything breaks apart. It's good that they say they can make it, but that doesn't make sense. Next, this is the 4th generation. It's an Astra implant, and they've changed it to this. Right? They reduced the angle. They made it by carving a groove, so it doesn't rotate. Hexagons get torn because the fixture does. Because there have been ongoing issues, they are currently changing everything. They are changing everything now. Only Korea hasn't changed, and all major companies have made changes. So this is how it is. But still complaining that Astra implant is not compatible, I think the dependency is too high. I think there's a lack of self-esteem. What can I say? It's a difficult situation. Because this screw keeps coming loose. There are also places that make this lower part elongated. You've heard of deep implants, right? There is a domestic company. It seems to be working with Biotem implants. Since the screw loosens too well, they lowered the hex and extended the connection downward. Then the screw would loosen less. However, it now breaks more easily. The fixture becomes weaker. Anyway, it's called deep implant because it's deep. There are places like that too. Anyway, there are also places that reduced each side by 5 degrees to a total of 10 degrees. Because it breaks. It says deepest here. 3.4 millimeters. Deepest. So usually the abutment connection is made at 3 millimeters, but this is 3.4 millimeters. It has become 0.4 millimeters deeper. The deep implant seems to be made about 1 millimeter deeper. So it cannot be made as 7 millimeters, 8 millimeters. It can be made starting from a length of 8 millimeters. Since the abutment connection is the issue, we keep trying to change something. We reduce the size of the screw threads above. Here, it is being reduced because of thickness. That's the way we're trying to keep making changes. This is a screw vent implant. This has about 3 connections. This is a Paragon implant. It's a BioHorizons implant. This is also a copied connection. It copied the screw vent implant connection. Zimmer implants are really good. So there are about 3 types coming out like this. Then there's the most famous Swiss Plus implant. This also has 3 connections. There hasn't been any successful cases with just 1 connection. The implants in our country have exactly 1 connection. Every company is 1 connection. Thinking about it, it's only convenient from the company's perspective. It's convenient for the doctor, but the most inconvenient for the patient. So we need to think about this. Next, reflect implants are going with the concept of making any connection. Recently, the appearance is such that, like us, it seems many are following this shape. BLX has also become somewhat similar, and we have been somewhat similar too, but we've optimized the design further. So we are going this way now. Whether internal connection or external connection, The biggest problem is that the seal doesn't work. The bioseal. It's called a conical seal. Bacteria enter the mouth and create gaps where they can grow. As a result, an environment develops where bacteria grow tremendously inside, which is a big problem. So due to the bacteria around, the bone has dissolved by 1.5 minutes. 1.5 has dissolved at the connection. Ankylosing implants are famous for having a conical seal that prevents the surrounding bones from dissolving. Then there are no screws. And the thickness is thick. The problem was that the abutment was thin, so it failed domestically. Do you know why it failed? Because all the abutments broke. This product had one connection. In southern China, right? People in southern China eat a lot of soft food, and they are relatively small. You can see that their chewing power is not strong. People in northern China have strong chewing power, so it is said that it still sells a lot in the north. I have shared some stories related to conical seals. The ankylosing implant initially did not have this structure at the bottom. Below. Non-hex implants come in our country. It's a mess. The ankylosing implant started out as non-hex, but it was a structure that could not be reinserted once unscrewed because there was no direction. So recently you can see that they have incorporated Torx. As you can see, Torx. It's the same. The geometry is different, but the concept is the same. This is the most robust. With the recent release of the Torx version from ankylosing implants, this doesn't attach at all. This side is floating. Eventually, this side weakens and causes problems again. This is how things like this form on the inside. So as you can see, it doesn't attach much. It only attaches 1.798 micron. It's weakened. In this way, the implant evolves. In the end, there's only one type of abutment: connection. So whether it's wide or narrow, the abutment connection is one type, and that's what we claim is good. There are both long and short ones, and the long ones are quite lengthy. We also got approval for up to 15 mm. It's necessary. There is also 15 mm. It will be placed in the back of the soft bone or in the anterior region. The anterior region is necessary, because if you place something short and thin, the implant twists while connecting to the abutment. It can't withstand the torque. If you try it, you will understand what I'm saying. And if you look at this, it's too thin. This part is all broken. That's what happened domestically. So it was completely removed from the domestic market. They prioritize convenience more. This was a brief look. Let's look at bicon implants. Bicon is also very weak here. All the parts that are wrapped around this are weak, so it breaks easily. Yes, it breaks easily and is thin as well. If you look here, it rises like this. So bone loss occurs up to here, almost at an early stage. It's thin, so when force is applied, it will move. It becomes banded and the bone dissolves. That's why I looked at single thread, double thread, and triple thread earlier, because triple thread is the strongest. When you look at it as a fixture, it doesn't break. These things are shaped perfectly to break. If you look here, these also have 3 connections: 2.0, 2.5, 3.0. I did 2, and then later added a 2.5 millimeters. But funny enough, the 3.0 millimeters breaks the most. This tube breaks. So we set the standard for molars at 3.6 millimeters. I also broke a lot, and many around me have broken them too. As you can see, there is an external hex, and inside there is also an internal hex. There are threads here, so it can be tightened with a screw. Bicon implants come out when placed in the anterior. If lateral force is applied, the locking mechanism releases. We tighten it to about 50 NCM with the screw. So far, only one has come loose. I think I didn't tighten that one properly. Sometimes the bone gets caught and won't go in. In that case, it's just that it can't be tightened, but it absolutely won't come loose. The fact that both anterior and posterior teeth can utilize locking is a significant advantage. So this is yes. With a 2.3 mm abutment post, it can be tightened up to 50 cm without breaking. It can be tightened further above that, up to 100 cm. Yes, However, the driver bends. Once you go above 50 nsakm, it doesn't tighten anymore, and the hex driver can't withstand it and bends. That's why hex abutments are recommended for molars. You cannot obtain more locking strength by turning. And it's double thread. We have also done a lot of research on this. Then there's the Straumann Implants BLX. This also has a double thread. It's also a torque structure. This was impressive. It's a side flute. Flute. Is this asking to be released quickly? It's called a chip pocket. Chip pocket. Chip. But this also becomes a screw. This part is cut, so when you rotate it, it goes in while cutting. So the feeling of placement is incredible. I think once we get our approval, it will be released soon, and the new sensation is extraordinary. Once you try it, you probably won't be able to take it out again. It will only go forward. It's really amazing. In the case of a triple thread, it goes in even more easily. So I think it's worth trying, and this is Torx, right? The reason we didn't choose Torx because the specifications are ambiguous. The R value and such specifications are not precisely defined, so they vary slightly between companies. So, this is 7 degrees. The angle of the conical connection here is 7 degrees. It's 14 degrees on both sides. ITI implants are 16 degrees. This is 14 degrees. I'm not sure about domestic implants, but they seem to hover around 15 to 16 degrees. That's the main approach, and this has a torque structure, but it's also one connection. So it breaks a lot. When you first look at the crestal module side, it seems to be 3.75 degrees. It's 4.0 millimeters. It's too thin. Since it's a one connection, fixtures with a small diameter are thin, and those with a large diameter have a considerably weak abutment. That's how this is made. The abutment is designed to catch here. However, these are bone-level implants. They are not subcrestal level implants like ours. Since it's not a sub-level, such ideas can be applied, but there is an unconditional advantage to placing it deeply. If placed deeply, such ideas cannot be applied. It seems that the person who designed it is an engineer. You know what that means. It seems to be designed by an engineer. It looks like a design by an engineer who knows nothing about dentistry. As a result, the one connection looks good. But if you're going to make this abutment, wouldn't it be better to make two? One for molars and one for anterior teeth? Right? So our SLX has a locking structure of 2.3 millimeters on the anterior side, and for the molar side, it has two of 3.6 millimeters, and then the TLX, Torx, has 2.5 millimeters on the anterior side. This is probably it. Then on the molar side, it has two of 3.8 millimeters. There are parts that cannot be solved with the one connection. So, if you're going to make a separate abutment for the molar side, I thought maybe we should also create a separate connection. That's our thought. So it's like they're trying not to make too many attempts. Our Torx++ structure is like this. The inside is Torx++. There is a separate structure called Torx+. We upgraded it one step further and named it Torx++. So this is the structure, and if you look, the threads above and below are different from each other. In the horizontal part, the bottom is like this, and above it, there is a taper section on top of the bottom horizontal part. It looks like it is turned upside down. We call this a couple force. It feels like the top and bottom are tightening together. So the bottom is hard to insert, but the top goes in quickly. Then when force is applied, oblique forces tend to withstand better where there are slants. Horizontal pressure is better tolerated where it is lower. That's how we think, and we designed it in an S shape for the platform switching design. It sticks very well. It not only sticks, but also seems to provide good distribution and absorption of occlusal force to the surrounding bone during loading. So it turned out well. So if you look at these things, there are hexagons and triangles, but here this part will break. Is it a trilobe implant? Nobel Biocare implants come out like this. And the top is triangular while the bottom is cylindrical. There are different types like this, and there's Straumann implants like this, and our BLX looks like this. Very solid. When we consider everything, we believe that the success or failure of implant treatment is ultimately determined by the implant design. I think that's correct. If you look at the design, the new design is also nice. This one will be much more solid than BLX and also easier to implant. We have a spiral lock with a cutting chip pocket like this. Here too, the bone attaches. Then it sticks well. I'm telling you this because I have experienced it. So what kind of implant do you want to use? The question is, what kind of implant do you want to use? That's related to surgery, and everyone wants to use implants that have cold welding at the abutment connection. They want to use an abutment connection without micro-movement. Then there's the gap movement. It's the same story. They want to use implants with a conical seal that provide antibacterial sealing. Ultimately, they want implants that do not emit bad odors and do not allow for the ingrowth of microorganisms. And they want implants that do not cause infections, resulting in no bone loss, with a platform switching effect that allows surrounding bone to grow back up. That's my thought. I believe that you will think similarly and will agree. Considering this perspective, regarding the implant design, it's about the fixture placement depth relative to the bone level. And everyone recommends planting it like this. Most people recommend it this way. We generally do around 2 meter. It's similar to beacon implants. Astra implants suggest about 0.5 meter, and then ITI implants also recommend to be placed about 0.5 meter deeper. Then Zimmer implants are around this depth, and Nobel Replace and Brainmark implants also aim to align the top of the crestal ridge with the hexagon. So, we think it will melt up to this point, and we design the module to be planted like this. Everything. Also, the abutment connection and the crestal module combination reacts very sensitively to initial crestal bone loss. So let's look at the results. In the end, I think the long-term results are about the actions and reactions of peri-implant tissue regarding occlusion. So this ultimately follows the implant design, right? Then it is determined whether the abutment connection becomes a switching platform or whether there is no micro-movement. Now, whether there is a biomechanical adaptation or reactive tissue remodeling is important. So the criteria for healing and loss or repair of crestal bone loss are determined by the mechanical story, by theory. The contributing factor is that there must be at least about 1 millimeter of available bone around the implant. And a large fixture is important. Only then can we reduce bone turnover late. Since the surface area increases, it can be calculated per occlusal load per surface area. Then cold welding must occur, and there must be no micro-movement. There should be no micro-movement at the abutment connection. Next, there needs to be a good occlusal environment. If that satisfaction is met, we believe it results in functional and aesthetic implant treatment. If this doesn't happen, eventually, the bone around the implant will disappear, osseointegration will break down, and peri-implantitis will occur, leading to continuous inflammation. Now I will talk while looking at the cases I have done. I did all of this too, below as well. If you look closely, it's the same Brainmark implant. It has corroded up to the first thread, and this has come loose a bit. So it has corroded a bit more. There is mobility, you see. This is the situation, and this is a BioHorizons implant. It has corroded completely up to the first thread. If you look closely, the bone has risen, but if you see, this part has lowered. A vertical pocket has formed up to the thread. Without fail, it corrodes up to the first thread. It is because there is mobility at the abutment connection. This is the same. It has melted a bit more. Let's talk about the internal hex. This is a Paragon implant. We now call the Paragon implant the Zimmer implant. It is made with an internal hex, so this is still attached. However, this part is ambiguous. Isn't it? If you take an X-ray, it seems that the labial bone has melted quite a bit. But it looks fine on the panorama. You can see that the interproximal bones are a bit melted, right? Still, it is maintained. If you have an implant and follow up, you can see that any implant goes through this. The labial bone, because if you look at the teeth, the roots are oval, but the implant is round. So the labial bone sinks down. These seem to maintain this thickness. So even if you do GBR like this, it all disappears over time. That is now soft tissue. It has created a pocket. So this is the biggest dilemma. If you only chase aesthetics, the result after more than 10 years of follow-up ends up like this. In other words, it means you shouldn't place thin implants in the anterior region. Everything disappears. The bone collapses and it's really hard. Yes, that's right. You need to choose an appropriate size. This is the biggest problem for me. And if you look at it like this, the color seems a bit different. Yes, the bones have completely disappeared. But now we are holding on with the interproximal, so it has ended up like this and then like this. The bigger problem when there is mobility is that the keratinized gingiva disappears. So you should never use implants that allow for micro-movement. I've experienced it a lot. It absolutely cannot happen. There won't be a solution. So this is the condition. This patient has a good occlusion. The CO is also fine. That's right. Next, let's try lateral excursion. Then there will be space. This patient has a good occlusion. So, the occlusal load is not applied. As you can see, even if you do it like this, it lifts. Yes. That's right. And then, even when it is completely milled, the front teeth are all lifted. It gets caught in the molars. And even if you do it like this on the right and left, nothing touches. When you bite with the front teeth, it does not apply a uniform overload. When you stretch it out, the entire area lifts as a molar guide. So in my opinion, the occlusal environment is good. The occlusal environment. If an overload occurred, I think it would have already fallen out. We have looked at such cases together. Next, it's the Astra implant that many Korean implant companies have copied. This is the data they announced. I think I scanned what was in the catalog. After the prosthesis, it has corroded this much after 5 years. So this means it's really good. They advertise saying this is material, demonstrating the greatness and good points of the Astra implant. In some ways, it's quite shabby. As you can see, the direction is not good, and without fail, crestal bone loss occurs. ITI implants are the same. There's really not much difference. It's a Swiss Plus implant. This one also melts all the way to the first thread without exception. It's identical. Locking taper, Baiken implant. This one is the same. This thread doesn't melt and doesn't rise this high. If we had used our S-lock, it would have risen this high. But this one doesn't rise. It's thin on this side, so it moves. This area is going to move every time it chews. It strangely doesn't rise. Next, let's look at our S-lock. If you look at the S-lock, this person is probably a cancer patient. So if you see, I don't understand how this was implanted so deeply. It's amazing how the prosthesis was done. Yes, that's right. But if you look here, the bone has all been absorbed. Since it's moving, bone can't grow in between these areas. It's fascinating. So I operated on the father of an acquaintance like this, and everything was maintained. Now we're also doing anterior surgery. The anterior teeth also underwent a secondary surgery like this. If you do it this way, remove the plug, insert the healing abutment, and depending on the situation, it seems like the surgery was done together that day. In the past, we only used hex. Now it will be done with a screw. But back then, we only used hex. It's the anterior area, and this one hasn't come out either. Strangely. So I shaved it from the outside and inserted it. Thus, when the temporary is done, it looks this clean. As you can see, this always results in gingival depression. This is a different case. This one had a good outcome. As you can see, implants are good. This is it. Isn't it good? This is another case. It's the same. After socket lift, insert it sub, and then when you do the prosthesis, the bone keeps rising as it is. Yes. So I removed the other side too. Plant it again, and the bone also rises again. This time I'm removing all of this side. I'm doing the prosthesis. It's been quite a while since I treated this patient. I remember it being over 10 years ago. Anyway, that's the situation. In the anterior region, there are cases like this. If you implant and use a prosthesis, it ends up like this. This is traumatic. In the end, the attached gingiva zone is maintained. I used a thicker one. I remember the diameter being 5.0 mm. So this is what is being maintained. It's the mandibular anterior, 3 incisors. Many people use locking because of this. Because you can't plant a screw type. It's too narrow. This happens a lot. I'm working hard to open this side. But the roots won't settle. I guess it's not this side, so I turn it back the other way. So I plant it wedged in between, and if I do the prosthesis like this, it's good. This is the best thing. I've done a tremendous amount of mandibular anterior surgeries. Not a single case has been problematic. It's unconditionally good. It's hard to insert too. This is natural bone healing after extraction. If you see, after pulling it out and then doing this, I planted it up to the bone level and the bone has risen this much. This is remarkable. It's unbelievable. This is all combined: locking taper, conical seal, and no micro movement. It's not bone grafting. This is a recent case. It's from 2016. In 2019, this became a bit uncomfortable, so you came back. In the meantime, this has all dissolved. I planted it according to the bone level, but upon further consideration, it doesn't seem right. So let's not do it this way. Let's do it like this. Since that day was the planting day, the original fixture was 7x9 meter, but I changed it to 8x7 meters. In my opinion, this seems correct. So I inserted this short and wide fixture subcrestally. Then if we wait, the bone will fill up completely. The other side has fallen out, and it looks okay. The bone will continue to fill up to here. I didn't touch anything else. If left alone, the bone will rise. So what if we plant on the opposite side and continue to do prosthetics? It's amazing. It's all filled up. The bone rises up to interproximal, up to the contact point. It's completely filled up to the proximal contact, and the back is a bit less filled, but that's just a matter of time. The bone is all filled here too. This patient's name is exactly the same as mine. The last name is the same too. So it stands out in my memory. My name is exactly the same. That's why this BioHorizons implant was done a long time ago, more than 20 years ago, and the patient came back after using it for a long time. It fell out like earlier. Such things can happen. What happens if the problem keeps not getting resolved? If left alone, the bone will naturally grow. There's no need to worry. Torx is similar. Torx also. That will also attach. You have to wait about 6 months. Yes. The hardest part is number 7. The cases I'm showing you now are typically cases that regular dentists cannot handle. However, among the implant patients that come to me, the ratio of single number 7 patients is about 10% to 15%. That's quite a lot. I guess typical dental offices receive around 5 to 10 single number 7 implant patients a month. But they will all give up. It's scary, they can't guarantee the prognosis, and number 7 is subjected to a heavy load. So the process of avoidance keeps repeating. If you leave it alone, it will adhere. The bones will fuse and continue to regenerate. Patients don't need to be afraid of going to another dental office. Even if they go to another office, in the end, they won't be able to do it, or there will be an incident. It's one or the other. Don't worry, and please say reassuring things. Just because you're doing a bone graft doesn't mean it will work. It only wastes money. And if you wait, the human body will recover on its own. Say it like this: then I will never go to another dentist. You need to attach the top. Do it like this with wire so that it doesn't extrude. But it has already separated. If it's separated, I tell the patient that a crown is necessary. I inform them in advance. And secondly, you can see that almost all of it is missing here. Originally, an implant should be done, but usually the patient does not agree. So I inform the patient in advance. Try doing a temporary and chew it, but it hurts. The day before yesterday, I took it out again and replanted it. If you just say to pull out the teeth, the patient might misunderstand. If you suggest doing a temporary restoration first and then deciding later, the patient will ask to have it pulled out first. You can pull it out then. There's no need to be greedy. If you don't get greedy and just leave it, the bone will fill up completely. I planted it like this. Nothing happens. You can see that the bone doesn't dissolve. The bone continues not to dissolve. In fact, the results of Torx are better than locking. Torx is a bit thicker, and the cylindrical type is thicker here. Post. If you experiment, you'll find that the post is sturdier than expected. So the results are better. The same goes for this case. The opposite side is also missing. Many patients like this come in. After being implanted and left alone, the bone fills in. It keeps repeating. If you look at this picture, it seems to have shifted up a bit. There's no initial fixation. It has shifted up. Still, the treatment continues, and we've done up to maxillary 7. Here, they used locking again. I wonder why. I don't know either. The top was done with locking, and the bottom with Torx. If you look, everything fills in. The bone rises. It rises here too. It rises here as well. It rises here as well. If you use an ordinary screw system, it's a disaster. Things loosen here and there, and if the bone starts to dissolve, it's hard to do dentistry. It's to the point where I dread going to work in the morning. You shouldn't do that. It continues to fill in. The surrounding bones become even harder. So think about it more. This patient came in with a company eye implant. They said they couldn't eat at all. This side is also difficult. They did this kind of work with a company eye implant, and it's possible because it was fixed to the palatal bone. Think about it. This is that space, but if you drill and try to put something in, what's going to happen? It doesn't make sense. So the dental clinic avoids treatment, and the patient just gets frustrated while nothing gets resolved. If you look, this is a blade. You know mixer blades, right? It's a mixer blade. It's just that it's attached as one body. It's appropriate to implant something this big. Right? You need to implant things like this. It seems like they put some bone here. It was probably a company B implant. I'm not sure. Below, they did an immediate implantation. They extracted it and implanted it right away. Now we just have to wait to see the results. After the second surgery, connect the abutment, and then there's also the other side. We have to do everything here, and we have to do this too. We have to do it all. Actually, we need to do everything except for that, but we tell the patient to do the urgent things first. Even if we say that, the patient knows everything. We have to exclude this too. We also need to exclude this. We have to exclude this too, and the middle part is all rotten. We need to exclude this as well. We will wait and see here, and we need to exclude everything else too. The patient knows. There's no need to hurry. So excluding this side, I planted again, and then I did a follow-up, and I also removed one side of this. After that, I've planted everything on this side. Right now, temporization is in place. So there's no need to fight with the patients. One of these is also missing. So it's currently in progress. No, this is a photo from October. It's from October last year. The bone is completely filled. The same goes for this. I did a socket lift, and it's overflowing from both the top and bottom. Right? No problem. In this case, it seems that this one caught in the middle might be a bit difficult. For now, since I planted something a bit thicker next to it, it should be fine. There was a case like this. This is the same as well. Remove it and plant it right away. And then the same goes for the top. After that, it will heal. I planted another one on top too. I connected it like this and finished. This is what I'm worried about. This is the superline implant, right? I'm worried about this. As you can see, there are bones growing upwards here as well. It was all done without bone grafting. It's all done using the existing bone. This kind of thing is a major appealing factor for patients. This is too small. As you can see, there is radiolucency around the implant fixture. In my view, the bone turnover rate has increased significantly. The screw is tiny. Compared to this, it's a small screw. So it is a bit risky. The superline implant also has a screw that is too small. I don't really understand why they do it this way. Personally, as you can see, our S-lock fixture has a thread-to-groove ratio of about 3:1. This is the optimal ratio I found. Anyway, there was such a case. Similarly, this is also case number 7. Remove it and implant. If you look at the CT scan, the cancellous bone below is not very good. But initial stabilization occurs in the lingual and buccal areas. These do not come out 100%. It lasts a really long time. That's why I'm telling you to implant wide. If you don't implant wide, it can't be done. So if you wait and take a look like this, it should be fine. So after the second surgery, you can get the prosthesis, like this. This bone is more actively responding, because it's anchored in the bone buccolingually. This was taken on the day of the final setting. It's not even a follow-up. This bone has already risen like this. I haven't done anything. This. How long do you think this will last? You have to do it like this. If you don't do it this way, it'll be tough. It's good. The fixation is good, and the results are really good. If you do it this way, I think it will be resolved without any major problems. In the end, the conclusion is like this. The success and failure of implant treatment depend on design as a decisive factor. Because there are only 2 companies in the world that can produce fixture abutments. It's a matter of whether to use grade 4, pure titanium, or an alloy. After conducting long-term clinical work, my conclusion is that ultimately design is the most important factor, and surface treatment refines that decision even more. And how perfect the prosthetic system is. It is precision management. We are putting in a considerable amount of effort into that. There are well-known companies, and I am confident that our products can guarantee precision comparable to those companies. Up to this point, I have lectured on implant design. I hope you have understood how important design is. That will be all. Thank you for your hard work.